All right, so as Stuart mentioned, my PhD was about the relationship between ABI, aggression, and violent offending. Now, I'm aware I have about 25 minutes to talk about just over 3 years of work, so I'm going to dive into what I did and the key things that I learned along the way. So acquired brain injury, or ABI as I'll be referring to it, is defined as any injuries to the brain that occur after birth and are non-hereditary, non-degenerative, and non-congenital. They can be from non-traumatic causes such as substance use and strokes, or traumatic causes like external injuries to the head, such as concussion and penetrating brain injuries. So the experience of sustaining an ABI can significantly disrupt the quality of life of survivors. But despite being a major cause of neurodisability, the related impacts of ABI are often inadequately understood and they're challenging to address through rehabilitation. One key area that is not comprehensively understood or effectively responded to is aggression and violence after ABI, despite such behaviours being commonly reported in this population. For example, aggression rates can range from 11 to 42%, and there are links between ABI and more severe forms of aggression like violent offending. Now, the literature base suggested that the neuropsychological changes occurring after an ABI can increase the likelihood of aggressive responses. In particular, areas like social cognition can be impacted by an ABI, and that can lead to impaired social decision-making abilities. So, for example, reduced insight into one's own behaviour and the behaviour of others, and difficulties expressing pro-social behaviour. But not all individuals with an ABI engage in aggression and violence, so neuropsychological factors alone do not entirely explain this relationship. Individuals with an ABI may also be at a greater risk of health and social factors that are independent predictors of aggression and violence. For example, increased substance use is very common after an ABI, and substance use is an established predictor of aggression and violence in general populations. But survivors of ABI often report health and social risk factors that were present prior to sustaining the injury. So it's unclear whether an ABI is exacerbating pre-existing vulnerability or whether it leads to the onset of vulnerability. There are also further issues such as ABI-specific support being very difficult to access, and survivors of ABI may receive less effective care for health and social factors. This could be due to things like poor practitioner knowledge and a lack of suitable interventions. There are also common challenges in ABI research that limit our understanding. So most studies rely on self-reported ABI and use self-report tools to collect information, which is a very common research method, but it can create problems for reliability and validity in ABI populations. So accurately responding to self-report questionnaires requires skills in comprehension and attention that are often significantly disrupted in people with ABI. So what that means is our understanding of the relationship between ABI, aggression, and violent offending was limited, and the role of risk factors was not sufficiently understood. So to support the development of effective rehabilitation for people with ABI that reduces the likelihood of negative health and social outcomes, improved understanding of the specific role of ABI in aggression and violence is needed. So my thesis aimed to identify how outcomes related to ABI can impact aggression and effective responses to aggression. So I used a mixed method approach as this was most suited to understanding both the independent effects and interaction of neuropsychological changes, health and social needs, and rehabilitation challenges. The first stage involved identifying whether aggression interventions developed specifically for or modified for ABI existed, and if they were effective. And if they weren't effective, whether there was sufficient evidence that could guide future rehabilitation efforts for aggression displayed by persons with ABI. So in my systematic review, I identified 16 aggression interventions. The results suggested that pharmacological management was largely ineffective, and anger management interventions demonstrated inconsistent effectiveness. Interventions based on emotion regulation were likely effective for externalized aggression, but not internalized aggression. Interestingly, both mindfulness and transcranial direct current stimulation were effective, and the results of a forensic peer group approach, which was the only forensic intervention identified, were promising, but these results weren't tested for statistical significance, so it's unclear if they were truly effective. Now, majority of the behavioural interventions focused on changing behaviour through skills training, but the interventions were not clearly modified to account for cognitive changes after an ABI. So the general lack of effectiveness of these interventions suggests that standard intervention types may not be responsive to ABI-related impairments, and interventions that are less cognitively demanding may offer greater benefits. Overall, long-term effects were generally not assessed, which limits our understanding of whether these interventions can produce sustained changes in behaviour. Also, there was commonly exclusion of individuals with more severe cognitive challenges, which means the evidence base for rehabilitation of aggression in persons with ABI is lacking applicability to individuals who may be at a greater risk of engaging in aggression and would benefit from these interventions. So in the absence of evidence-based guidance for reducing aggression, I then explored rehabilitation for other health and social factors, which, if unaddressed, could increase vulnerability to engaging in aggression and violence. And I achieved this through qualitative exploration of community-based practitioner perspectives. So I focused on practitioners to really gain an understanding of the realities of service provision and barriers in rehabilitation, as well as practitioners having unique insight into service user needs and challenges and outcomes. So I conducted semi-structured interviews with 8 practitioners from Victoria, Australia, and analysed this using an interpretive phenomenological approach to capture the nuance of service delivery in the context of ABI. So the interview schedule explored practitioner understanding of ABI and commonly observed impacts, the way in which services responded to service users with ABI, and barriers in delivering effective care. So the participants outlined that ABI can lead to poor mental health, substance abuse, aggression, cognitive difficulties, and poor treatment outcomes. Mental health challenges were linked to the negative impacts of someone's life changing considerably after sustaining an injury, while substance use and aggression were suggested to be the result of maladaptive coping. While community-based practitioners were generally aware that an ABI can lead to changes in functioning and can affect cognition, the more invisible consequences of ABI, such as executive dysfunction and social cognition, were frequently overlooked. So ABI was not systematically screened for or assessed in any of the non-ABI specific services. There were a small minority of participants who had received ABI-specific education externally to their current role, and that informed their awareness of service users who may have had an ABI and the adjustments that they made in their service delivery. In the non-ABI-specific services, there was only one service that provided a modified intervention for people with ABI, and many practitioners were just relying on informed modifications based on their prior experience. Interestingly, even within ABI-specific services, participants noted that there was a lack of current information about ABI to guide their approach, particularly when dealing with challenging behaviour like aggression. So all participants emphasised the need for adequate resources in terms of having access to ABI-specific training and education, and all participants noted that this was severely lacking. So without this ABI-specific education, practitioners are realistically limited in their capacity to effectively modify care for service users with ABI. Inaccessibility was also a key barrier. So in particular, participants described the difficulties of accessing neuropsychological assessments to get a diagnosis of ABI. These assessments are highly costly and there are long wait lists. There are also critical challenges described with accessing the National Disability Insurance Scheme. So the current system requires that people applying have a high level of cognitive ability to complete applications, and services that support individuals to do so are not always available. Moreover, the National Disability Insurance Scheme requires individuals have a diagnosed ABI to be eligible for support, but given substantial challenges in securing a diagnosis, this may result in many people not accessing the support that they need. So overall, the findings of the study indicate that there are widespread challenges providing adequate care to persons with ABI, and that persons with ABI experience a range of complex negative health and social outcomes that require effective care to support their right to thrive and not just survive. Now, I did a second study using the same qualitative data. This time I focused on practitioner perspectives about the role of ABI in violence. So in the prior study, a lot of the outcomes of ABI that were described are common precursors to aggression and offending. So in second half of the interview, practitioners were also asked about their opinion on the role of ABI in violence and what they considered to be contributing factors for violence. So what is represented in this word cloud are the most common terms that appeared across all the participant responses. Those that are larger indicate the more commonly referred to terms. So when participant responses were integrated, the results highlighted that the risk of violence comes from an interaction between ABI-related neuropsychological changes alongside health and social factors and systematic barriers. However, many practitioners were not explicitly aware that an ABI can have an exacerbating influence on these factors. They often described health and social factors as things that independently increased risk, but they were less aware of how ABI can compound the negative impact of those factors. So participants who reported more extensive experience, so those who had 10 years or more working with survivors of ABI, and those who had also received ABI-specific training generally demonstrated more of an awareness about how neuropsychological changes can impact decision-making ability in the context of violence. However, a key finding from this study was that many participants actually presented with misconceptions about ABI and violence. There was a common belief that violence was either a choice or a result of personality. What was interesting was there was a large discrepancy between participants recognizing the influence of ABI on cognition, emotion, and frustration when they were talking about general impacts in their previous study, but then overlooking the influence these changes can have on increasing the risk for violence. So practitioners who work with survivors of ABI who consider behavior to be a choice may be unaware that executive dysfunction can actually disrupt someone's ability to make informed decisions due to a reduced capacity to both consider the consequences of behavior and to generate appropriate social responses. So the perspective that behavior is a choice and that individuals can learn to modify their behavior is a very common perspective in behavioral change. But without ABI-specific education to address some of the limitations of this perspective, individuals who work with survivors of ABI may be delivering rehabilitation approaches that are ineffective because they're going to be overlooking the unique impact that ABI can have on behaviour, particularly aggression and violence. So the prior literature base and the practitioner perspectives obtained through my PhD identified key risk factors for violence that warranted further quantitative exploration. Due to the challenges associated with self-report methods, I undertook 2 studies using data linkage. So data linkage involves matching de-identified records across different administrative data sets without direct recruitment, and so it bypassed a lot of the constraints of active participation. So retrospective data linkage was conducted on individuals who presented to a Victorian emergency department for a traumatic brain injury when aged between 18 to 25. The focus here was specifically on traumatic brain injury, as these types of ABI are quite easily identifiable within administrative data. So data linkage was undertaken through the Centre for Victorian Data Linkage, and an integrated data resource was created that linked the TBI data to health and justice data. So as survivors of TBI often experience high rates of adverse health and social outcomes, irrespective of aggression and violent offending, it was necessary to understand the role of such factors by comparing these characteristics from people with TBI who engaged in violent offending to those who did not offend. So in study 4, I determined the prevalence of incarceration for violent offences within the cohort and compared the characteristics and risk factors within this cohort for those who committed violent offences to those who did not. Now, I will note that this study excluded individuals who had only committed non-violent offences, as the number of participants in this subgroup was not suitable for comparative analysis to the other groups. So the proportion of individuals who were incarcerated for violence over the study period was almost 4 times greater than the prevalence of violent crime perpetration in the general population. In terms of socio-demographic factors, the recorded prevalence of males was about 1.3 times higher in those who had engaged in violence compared to those who did not, and this was a significant difference. Indigenous Australians were significantly overrepresented in the group who were incarcerated for violence, with a prevalence rate that was around 61 times higher than those who did not engage in violence. So those who were incarcerated for violence reported a significantly higher prevalence of both risky substance use and poor mental health indicators when compared to those in the community-based group. And this was consistent both prior to TBI and after TBI. On average, those who were incarcerated for violence experienced risky substance use events between 4.5 to 13.5 times more than those who weren't. Similarly, for mental health, they experienced poor mental health events between 3.5 to 5 times more than those who were not incarcerated for violence. The sample also reported quite an elevated rate of recidivism at around 73%, which compared to the general recidivism rate reported in Victoria is 49%, so quite elevated. So the last study extended on the previous study by employing single event survival analysis and Cox proportional hazard regression on the full linked data cohort. This was done to investigate trajectories of incarceration for violence and explore how risk of incarceration for violence was actually impacted by substance use and mental health and a history of incarceration while controlling for sex and Indigenous status. And in addition to investigating pre and post TBI health factors, I also investigated how participation in substance use or mental health treatment would impact risk. So individuals with TBI were incarcerated for violence at a rate that was around 3 times higher than the general population across the same time period. And the first incarceration for violence occurred on average 2.5 years after sustaining a TBI. For pre-TBI factors, substance use emerged as the most salient risk factor, followed by mental health and incarceration for violent offending, whereas pre-TBI non-violent offending did not significantly affect risk. So the impact of pre-existing health comorbidities suggests that services should be aware of how these factors may heighten vulnerability to long-term violent outcomes. This information is essential when conducting assessments of service user needs and determining accurate priority levels and levels of risk. So, comparatively, for non-violent offences after TBI, this was a considerably high risk, and it was the highest risk factor for individuals who experienced 4 or more incarceration periods. So they were at almost 25 times higher risk for entering the prison system for a violent offence. Post-TBI substance use also indicated a significantly increased risk. And interestingly, individuals who completed treatment for substance use or mental health problems also faced an increased risk of incarceration for violence. Now, this could indicate potentially greater severity of presenting problems that elevated the risk for violence. But when considered with the earlier qualitative findings and prior literature, it may indicate that current service approaches are failing to effectively address these issues. Critically, what this study showed was that ongoing criminal justice contact is a major risk factor for incarceration for violence in persons with ABI. And it also suggests that there are many opportunities prior to violent offending where an individual with an ABI could receive effective care that would prevent that behaviour from occurring. So in summary, persons with ABI are significantly underserved in current rehabilitation systems. Overall, the approaches and interventions employed lack responsivity, and they're not suitably modified for persons with ABI. This is then further exacerbated by an absence of evidence-based education about ABI that is available to practitioners. So lack of practitioner knowledge about ABI and biased assumptions could limit the quality of rehabilitation and increase those negative outcomes. Additionally, disability systems are set up in a way that is challenging for survivors of ABI to gain access to them, meaning that there are individuals with ABI who may be engaged in generalist services that are not equipped to support them, or they may not be accessing services at all. My findings demonstrate that there is a strong relationship between ABI aggression and violence, and that survivors of ABI face greater vulnerability to entrenchment within the criminal justice system. What it shows is that ABI itself is a risk factor. It can exacerbate pre-existing vulnerability, or it can lead to the onset of health and social needs, which may then exacerbate the likelihood of aggression and violence, through independent effects of these needs, as well as the interaction with ABI-related neuropsychological challenges. The difficulties in service provision also mean that survivors of ABI may often have unmet or undermet needs that are contributing to that increased risk of aggression, which can then culminate in the display of more severe behaviours that are likely to be more criminalised as violent offending. So mitigating violent offending outcomes for survivors of ABI requires enhanced interdisciplinary responses that integrate ABI identification and ABI-informed care across health, social, disability, and justice services. Conducting routine screening at multiple contact points could ensure that a greater number of people are picked up as having an ABI and diverted to appropriate services. This could be assisted by the use of shorter cognitive assessments that could be beneficial for generating an initial understanding of cognitive impacts, which can then be used to inform service delivery where neuropsychological assessments are difficult to access. But as evidenced through my PhD, it's not only important to increase identification of ABI. There needs to be adequate rehabilitation approaches used within these services to guide care. So there is merit in further development of ABI-specific interventions that are actually responsive to the unique impacts of ABI. Additionally, embedding ABI-informed education frameworks into standard practice could help make a system that works for people with ABI rather than against them. Similar to how trauma-informed approaches address trauma, ABI-informed education could improve practitioner capacity to recognise the signs of ABI, understand ABI-related impacts, and actually respond to ABI in a way that accommodates for the unique impacts. So overall, responding appropriately to the various impacts of an ABI requires coordinated approaches. So coordinated care approaches such as link worker services have been trialled in the United Kingdom, and link workers assist survivors of ABI during the transition from prison to the community by identifying their needs, facilitating access to relevant services, and supporting them to stay engaged with those services. Initial findings have demonstrated promising effects for these services in better rehabilitation outcomes and reduced recidivism. And it's important that ABI needs to be considered as a long-term condition that requires ongoing care for health, cognitive, social, emotional, and behavioural changes. So the introduction of coordinated care services should not just be within the criminal justice system, but community services could benefit from coordinated care systems that facilitate that delivery of integrated care. So we're addressing needs in a more holistic way rather than trying to address them all separately. And this holistic way of addressing needs could prevent aggression and violent offending outcomes. So I thought this participant quote was a good way of capturing the essence of the issues I explored in my PhD. So to sum up, ABI is a key risk factor for aggression and violent offending, but relying on the criminal justice system for rehabilitation of ABI-related needs and behaviour is ineffective, and it will perpetuate negative outcomes for survivors of ABI. The factors that contribute to aggression and violence can feasibly be addressed prior to criminal justice contact and through linkage to appropriate services after criminal justice contact. However, there needs to be substantial changes to the conceptualization and application of post-ABI rehabilitation. And that is it.
Thanks very much, Tahnee. That was a fantastic presentation and very impressive, covering an entire PhD in such a short time. Look, if you're happy to unshare your screen so we can see people's faces, we do have some time for questions. Looks like we've got a pretty good turnout today. So, look, if anybody wants to go first, please feel free to unmute yourself, or if you prefer not to do that, you can also put a comment in the chat and I'd be happy to read that out on your behalf. But the floor is open. I told you this would happen, Tahnee. First question is always the tricky one. I might ask a first question if I may. You made lots of really important points that seem to follow from your research. One is about the importance of routine screening, and it made me think of a conversation I had in another criminal justice setting the other day. where there's a team that's been funded for enhanced screening. But the problem is they now are getting better at identifying the problem, but with no more resources for responding to the problem. And I'm wondering if you have any reflections on that in the context of ABI in prisons.
Yeah, absolutely. Like the interventions that are available within the justice system for people that have an ABI are already very limited, and the wait lists for them are incredibly long. So, with increased identification of ABI, there's going to be much more demand for those modified interventions. But more funding for these interventions is warranted because if majority of the prison population may have an ABI, then you should be providing interventions that accommodate for ABI related impacts.
Yeah, thank you. We just need more money in the system, right?
Yes.
Well, I noticed from the Report on Government Service the other day that we're over $7 billion a year in net recurring costs for prisons in Australia. So there certainly seems to be some funding somewhere in the system anyway. Look, I see there's a comment or a question in the chat from Thomas Goodwin saying, in study 4 and 5, who is included in the TBI sample and how does one get a TBI label in the data sets that you accessed?
So in the sample, we included, so very specifically, it was we looked at individuals who were born in 1991 to 1993, and we captured incidents of traumatic brain injury when they were aged 18 to 25. So we used emergency department data to do so. So there are ICD-10 codes for traumatic brain injury, um, which I can't remember off the top of my head, but you can identify them in the administrative data. So they're classified as having a traumatic brain injury at that point in time.
Yeah, and just in terms of the nuance of that, Tahnee, there's a follow-up from Thomas. Does this include mild TBI/concussion?
Yes, it does.
It does. Great. Look, and there's, I mean, our group does a bunch of work using linked data as well, and there's that incredible strength that you can get population samples where what you care about has already been measured. But the limitation, of course, is that someone needs to have shown up to the hospital and got a diagnosis. And maybe that aligns with what Thomas Goodwin's alluding to there. I wonder if you can just reflect on ascertainment of ABI and TBI. I know ABI and TBI aren't quite the same, so it might be useful just to, I know you've made that distinction for me before.
Yeah, it's very interesting. I guess like the main benefit of administrative data is you can use those ICD-10 codes to capture concrete incidences of traumatic brain injury, but not everyone who suffers a brain injury will go to emergency department services. And so sometimes the use of self-report data in conjunction with linked administrative data is helpful because you're capturing both the people who have been to health services and also the people who may have sustained an ABI and not gone to those services, but they know that they have an ABI as well. And of course, with the data linkage focusing just on traumatic brain injury, it does exclude non-traumatic forms. And that is largely in part because they are a lot more difficult to actually diagnose. So, for example, substance use related brain injuries have been suggested to increase risk of violence after a brain injury. But it's very difficult to diagnose when that happens because it's not like there's a specific incident where chronic substance use turns into an ABI that doctors can look at and go, this is a point in which you actually sustained an ABI.
Yeah, so it's a more gradual process.
Yeah.
Yeah, look, I mean, I'm just going to keep on asking questions until somebody else on this call does. So there we go. Great. Lindsay, please go.
Sorry, Stuart put the pressure on, so I had to put my hand up. Thanks so much, Tahnee. That was really fascinating and amazing piece of work, and congrats on wrapping that up and submitting your PhD. My question's kind of a bit of ignorance. I'm really curious. What are the main differences in, I guess, functional impairment and other symptoms between intellectual disability and acquired brain injury? And we know from the Banksia Hill study in WA that I think it was around 90% of young people there had some sort of brain injury or intellectual impairment. So I'm just wondering, do those kind of go hand in hand, and are the responses similar? And I guess furthermore, that was a youth justice study. Would it be different in adult settings in terms of how we respond?
Yeah,
Sorry, that many questions, so if you need to get me to repeat it, I'm happy to.
No, that is a great question. Generally, there is some overlap between kind of the cognitive impacts between intellectual disability and ABI, but there are a lot of very nuanced differences, and they impact the way that we respond to people with intellectual disability and people with ABI. One of the key differences for people with ABI is that the changes in cognitive function have happened after birth and oftentimes after someone has gone through long periods of development. So the way that the structure and function of the brain is different to someone who was inherently born with those differences. And some of the key differences in acquired brain injury is a lot of the frontal lobe impairments, particularly those relating to executive dysfunction and social cognition. Social cognition in particular, there's a lot of links between aggression and challenges with theory of mind after an ABI. So difficulties understanding your own behavior, what other people's behaviors and what they're thinking about their behavior, and what other people would think about someone else's behavior. That is a very key impairment in social cognition that has been found in survivors of ABI. And so that can lead to a very specific kind of challenge with social moral decision making because of that misunderstanding of behavior. And so that's been a key difference in people with ABI. And the theory of mind impairments are actually also quite similar to those that have been reported in people on the autism spectrum as well. So there are a lot of crossover with the types of impairments people with ABI experience, but there's also something unique to their experience that separates them from other groups. And a lot of that pertains to this is not something that they've always lived with, something that has happened to them that has dramatically changed their lives. And that in itself can be incredibly difficult for someone to cope with. And that can lead to those increases in health problems like poor mental health and substance use as ways of coping. I think I've answered your question. Let me know if I haven't.
No, that's amazing. Thanks. And then my final last minute question in the question was just around would there be any differences in how we respond to ABI in youth settings versus adult settings, or is it quite similar?
I think that there would be some differences in the way that it is responded to. So if we look at a brain injury that someone has sustained when they're a child or a young adult compared to someone who's in their 30s or 40s, children and young adults, their brain is still in that process of development, particularly the frontal lobe is still developing. And so what often happens if a young adult sustains a brain injury, they haven't initially developed those skills because their brain was still growing. Whereas someone who sustains it later in life, their brain did fully develop. So there is going to be a difference between interventions that are teaching people to acquire new skills that they never really had before compared to regaining lost skills.
Thanks so much.
Thanks very much, Tahnee. It's great to see. Thank you, everyone who's putting their camera on. Special shout out to Glenn Cooper, who's, I think, doing that in the car. Good on you, Glenn. Appreciate that. Look, we've got a couple of questions. I think it's Georgia Campbell and then Shorts NZ.
Thanks so much, Tahnee, for that presentation. I work in ABI and I just wanted to query if along in your many years of study you came across a couple of things which I think are useful developments in this area, one of which being the work that Synapse are doing in the Gunny Way screen that they've developed. I'm not sure if it's something that you're familiar, and they have much more of a presence in Queensland, but it's a screening tool for cognitive changes as a result of an ABI, but they don't need to be administered when someone has a diagnosis, of ABI, but it's been developed by First Nations people for First Nations people and can only be administered by a First Nations assessor. And they're working primarily in the justice system and doing some pilots within the court system of developing a support needs report, basically, to to try and guide the courts in accommodating for that cognitive decline as a result of either a diagnosed or an undiagnosed ABI. And the other thing I suppose I was just wondering if you came across in your studies is some of the work that's being done out of Monash about a positive behaviour support plus, which you're so right. There are so many interventions that don't accommodate well for the cognitive and emotional changes that can occur after someone has experienced an ABI, but that is one approach that has been developed specifically for the ABI population. I don't know if they've looked into kind of any interface with the justice system. They've kind of been, I think, focusing on providing some training within both the public and private sector of rehab, but I think it would be a really interesting sort of facet of that research and that approach to see if that approach can be, or if there would be any modifications that would be required to be administered within the justice system, but also if there was any way to review like the efficacy in reducing contact with the justice system after receiving an approach that's specific for trying to help someone to manage any kind of challenging behaviour after ABI.
Yeah, thank you, Georgia. Those are excellent points. In terms of the screening tools, so the screening tool that is coming out of Synapse is amazing, and it's a much needed development. So for a bit of background about ABI screening tools is historically they've been quite limited, but we are recently seeing the development of tools that are more accurate at identifying an ABI and use clearer, plainer language that is easier for someone who has cognitive impairments to understand. So there are great tools also from RBias in Victoria. I think one of the major issues is that services just don't use screening tools at all, like proper cognitive screening tools. A lot of the times it's just, have you ever had a brain injury? Yes, no. And that is the extent to that. And someone might not know that they have had a brain injury. They might not have even been told that they've had a brain injury. Even if they've been to hospital, there's been cases where people go to the hospital and they have a traumatic brain injury, but they're not told when they're leaving, you have a traumatic brain injury. And they find out years after that what happened to them was a traumatic brain injury. So there definitely needs to be a lot more funding into developing ABI screening tools, and whether that's just embedded into cognitive screening tools more generally to cover sort of all bases, that would be amazing. In terms of positive behavior plus, I have heard of it, and that's kind of, I guess, the next steps for where I can take the findings of my thesis afterwards. It is actually using what I found to help the development of those sorts of interventions to also be more specific to people with ABI, but also be adapted so that they could be used, for example, in prison. So if there are more effective interventions in prison when someone enters there after they've had a TBI for a non-violent offence, maybe that would stop reoffending and they wouldn't be at that elevated risk of violent offending.
Amazing. That's so good to hear. Thank you.
Thanks, Tan. And I just see there's a comment from Thomas. Georgia, if you're able to share a link to that screener, it sounds like there's some interest in maybe people wanting to have a look at that. Shorts NZ, over to you.
Hi, thanks for that great presentation, Tahnee. My question's about that small percentage of women in your study. And as we know, for acquired brain injury for victims of intimate partner violence, over 90% of that is acquired through hypoxia from strangulation. So my question is about, I'm looking at interventions here as to where we can possibly reduce the risk of victims of acquired brain injury or traumatic brain injury in the first place. Certainly our figures here in New Zealand show that over 94% of injuries that take our intimate partner violence victims to hospital are to the neck or above. Now that's huge, 94%. So, and only a very small percentage of those actually, of course, go on to only a small percentage actually even seek treatment in the first place. So I guess my question to you is, when you were gathering your data, Did you look at what the causes of the ABI were in the first place?
Yes. So in terms of the causes in ED data, there was no sort of data that said this is from specifically intimate partner violence. It was coded as, things from assault. And so if I were to do this again, I would use other variables like clinical notes for ED presentations to identify whether someone was attending the ED for a TBI that was related to intimate partner violence. I'm doing collaborations with researchers from Canada who focus on intimate partner violence related to brain injuries. And there are definitely ways that it can be identified. So, for example, using emergency department data in conjunction with ambulance data and police data to get a more complete picture. That was the intention of my PhD, but unfortunately, data linkage is very expensive. And we did not have the funds to include all of the necessary data sets to be able to accurately determine if a brain injury was related to intimate partner violence. But it is definitely an area that needs attention. So, like, past research has found that women in prison who are in prison for violence are more likely to have had a brain injury from intimate partner violence themselves. So it's definitely a key risk factor. And I think it also shows the benefits of not just using linked administrative data, but combining that with self-report, with qualitative data to capture the people that are still flying under the radar, essentially.
Thanks for that. That was a really important question. Thank you. Look, we've got a couple of questions in the chat as well. The first from Emma to Ferga. Emma, do you want to ask that yourself, or do you want me to read that one out? Oh, just working on the unmute.
Sorry, Stuart, you can read it out. It's just a comment.
Okay, no, look, it's a great point. So Emma says, thanks for the lovely presentation, very insightful. And Emma says, for the work that I do with Indigenous communities, aggression after ABI is often medicalised or criminalised, but rarely contextualised. Nice phrase, Emma. That was pretty good off the cuff. For Indigenous people, especially those with incarceration histories, it's vital to understand aggression not just as a symptom of injury, but as embodied response to cumulative trauma dislocation from country and systemic neglect. And these responses need to be culturally grounded, such as relational healing and cultural ways of managing distress behaviour. Without considering this, we risk misinterpreting pain as violence and continuing cycles of criminalisation. And I see 1 thumbs up and 3 love hearts on that comment already, Emma, so it sounds like there's some support for that. But Tahnee, I guess, really keen to hear your reflections on that.
I mean, I think Emma said it a lot better than I did in my thesis. Yeah, so while Indigenous Australian perspectives weren't the primary focus of my PhD, when that finding came out that they were like over 60 times overrepresented, and I attributed that likely to the enduring impacts of intergenerational trauma, as well as the fact that there is a lack of culturally appropriate health service approaches. So it's kind of like, everything is exacerbated. So we know that health and social services aren't effective for people with ABI, and it's even less so for Indigenous Australians who have an ABI because of that absence of culturally safe and appropriate support. So they're facing an even greater risk and vulnerability and are subjected to different social factors like overcriminalisation of behaviour as well. So they're an incredibly vulnerable subgroup that definitely needs further research in this space to get their perspectives and figure out what we can do better.
Thanks, Tahnee. And if you've got any response to that, please feel free to unmute. Otherwise, we'll keep going. Look, the next. Sorry, Emma, did you want to respond to that at all?
Oh, sorry.
No, it's good.
No, that was lovely. Thank you, Tahnee. Thanks for that.
No
And I
worries.
think, and I think that was very insightful. And I think there were so many things that come out of Going back to the question, I think there was a lovely woman that asked a question from New Zealand regarding the intimate partner violence percentage, because we did have very similar findings from the Beyond Violence project we did a few years back in WA. And it was quite a high, around over 90% of those women that with intimate partner violence were recorded but we didn't capture as much as possible as to the reasons, but it was all around strangulation. In terms of strangulation, I was so interested to hear your reflection, your presentation, and the impact of that, and the percentage that you have in your study as well, which is a potential interest area to look at as well, capturing some of the critical reasons why, and a lot of those women had been identified having to go through concussion when they reported through some of those findings. So, but lovely. But I just want to stress, Tahnee, and I suppose it's really from a critical perspective of being in the criminological space, when we talk about violent offending among those Indigenous people, that kind of really need to shift the lens around individual pathology in terms of, structural and historical context of what are some of the scholars such as Chris Cunin and some of the other ones have called out, in terms of, the violence of the state themselves. And for many of those, violent behaviour kind of really shaped the lifetime exposure to those trauma, racialized policing and all, the type of that stuff, institutionalization, in many cases kind of really seen, unrecognized in terms of trauma brain injury. So, and these aren't just criminal justice issues, they're really kind of like health and healing issues for most of the people, especially for the Indigenous who are involved in the criminal justice system. And yeah, so that's just, another issue that I just want to mention based on the client group that we're working with as well. But brilliant presentation, thank you. That was very, very interesting, lots of questions. And
thanks, Emma. Those are great points. I see Glenn Cooper's got his hand up. Please, Glenn, over to you.
Yeah, hi, thanks, everyone. Again, more of a statement rather than a question, but I work with men as they leave prison, and many of whom have an ABI. And I guess my frustration, you mentioned in your presentation needing that diagnosis for the NDIS, but I'm finding quite often I've got the confirmation of a diagnosis. What I need is how that diagnosis impacts their cognitive functioning for that individual. So it would require an FCA, a cognitive functioning assessment, which costs $3,500. And I reckon I might only secure that funding 1 in 15 times. And when I get that and get them onto the NDIS and they've got these access to resource and therapies and so forth, they go on to do really good things. It's the 14 others that I can't secure the $3,500 for the FCA for, that get trapped in that cycle and return to custody. And I guess that's the frustrating for me on the ground floor, is finding, yes, we've got the diagnosis, but having the evidence of how that impacts their daily cognitive functioning is the challenge that I'm always sort of up against. So, yeah, more of a statement rather than a question, but thank you. It's really good.
No, thank you. Yeah, you've raised a really great point there that, the diagnosis and accessing NDIS is just the tip of the iceberg. And there's been a push for the NDIS to actually fund cognitive assessment for people with ABI. Currently, they don't fund it, which is unfortunate, but it's a really critical resource that is needed, which is why I also talked about having the shorter cognitive assessments that would be cheaper than a full neuropsychological assessment. And obviously, they wouldn't be as in depth in terms of everyone's specific impairments, but they would give a much better idea of each person's unique cognitive impacts that could be used as kind of a jumping point to access proper NDIS support and then get the funding for a diagnosis. But it's a very, very complex issue, and a lot of my participants expressed a lot of frustration about the challenges with the NDIS and how it's not set up to work for people with ABI. And even if they do get access to NDIS, it's often difficult to get some financial support for what they need, so like mental health support and behavior support. So that's just another challenge that happens. So there's just constant hurdles in the way.
Thanks, Glenn. Thanks, Tahnee. Look, probably last question in the chat from Natalia over in Gadigal and Sydney. Just wondering if temporal onset was examined, which came first, e.g. criminality, substance use, or ABI, and whether this influences access or provision of services.
I did look at kind of the incidence of pre-TBI health and social factors compared to post-TBI. So the TBI that was used to identify the cohort, that was purely individuals where that was their first traumatic brain injury. So they had no pre-existing traumatic brain injuries. And the rates of things like substance use and poor mental health were relatively high prior to the injury, but they significantly increased after the injury. So, for example, for things like substance use, it was around 20% had pre-existing substance use issues, but then that jumped up to over 50% in the people who were incarcerated for violence. So there is an element of that pre-existing vulnerability that is being exacerbated, but what we are seeing is that actually sustaining an ABI triggers the onset of those problems as well.
Thank you.
So not a clear case of one leads to the other. It's multi-directional and
Yeah.
compounding causality.